Next, we have Dr. Renu Grover, who will be presenting on the accuracy of biometry calculations in pediatric cataract.
Welcome, ma'am.
Good evening. So this study was conducted at Eye Hospital. This is a retrospective study. It was done over a period of 5 years. It was January 2019 to January 2024. All the patients had at least 1 year of follow-up period, and each eye of the patient was considered as one case. So total number of patients were 300, age group 6 months to 12 years, and all patients underwent cataract surgery with intraocular lens implantation under general anesthesia. So we divided the patients into 4 groups according to the age, 6 months to 2 years, and then 2 to 4 years, 4 to 8 years, 8 to 12 years. So the patients, children excluded were preterm babies born before 37 weeks of gestations or more than 12 years, age more than 12 years, complicated or traumatic cataracts, pre-existing corneal retinal pathology, neurological disorders, glaucoma, nystagmus, or any previous intraocular surgery or laser therapy in the same eye. So these are just graphs saying this is the number of the patients which were taken. The maximum number of patients were between 4 to 8 years, and female more than male. This is a table of a graph of the morphological types of cataracts. Lamellar cataracts were the most common in the age group that we took, followed by total mature cataracts. Okay. This was just pictures of the instrumentation used for calculating the IOL power. So just emphasize on the formulae which were used for calculation of the power. So as you're aware, we tend to leave the child hypermetrope so that as the child grows and the eye elongates, there is a myopic shift. How much to leave the child hypermetrope is what is the challenge. So we followed this formula by Dahan and Residue for children less than 2 years under correction by 20% or using the axial length only, and for children between 2 to 8 years under correction by 10%. So based on the axial length. And we also incorporated this target post-op refraction using the formula by Enyadi et al. So this is the tables showing that for 1 year we targeted a post-op refraction of +6, and similarly according to the age group the refraction was targeted. We had a target refraction. So this is just graphs showing that a lot of times we got surprises on what we actually targeted to what we got immediately post-op. So this is just a graph showing that most of the patients that we targeted hypermetrope were hypermetrope, especially in the younger age group, 6 months to 2 years. And in the older age groups, we did not target a hypermetropia, we targeted a emetropia. So just like to emphasize that this is the results at three weeks. This was 40% of the patients were myope already. There was a myopia of 40% in the age group of 8 to 12 years at 3 weeks, 37.1% in 4 to 8 years, 35% in 2 to 4 years, and 14.8% in 6 months to 2 years. So despite targeting a hypermetropia, we still got a myopic shift at 3 weeks. And at 1 year, maximum myopic shift was in 6 months to 2 year age group. This is 37%, not maximum, 37% had a myopic shift, 63.6% in 4 to 8 years. So this graph shows the hypermetropia. This is, the blue is 3 weeks, 3 months, and 1 year. There is the hypermetropia goes down and the myopia goes up. So the next part of the study was, these are the formulae that we used, the SRKT, Holiday 2, Hoffer-Q, and Barrett 2. And in short, I'll just tell you this, the orange is, blue is the myopia. So maximum, Hoffer-Q was the best one, followed by Barrett 2 was the most accurate formula we found in our study. So to conclude, maximum amount of myopic shift in pseudophakic children at 1 year follow-up was found in the age group of 6 months to 2 years. The Hahn and Residue's recommendations for undercorrection of IL power failed to provide a desired post-op refraction in our studies at 1 year follow-up. This is in Indian eyes. At 3 weeks follow-up, maximum cases of myopia instead of targeted hypermetropia were observed with SRKT formula and minimum with Hoffer-Q. Holiday 2 formula was least predictable for calculating IL power in the age group of 6 months to 2 years, and Barrett Universal 2 formula found to be the most accurate, followed by Hoffer-Q. So our recommendations are that more undercorrection of intraocular lens power is recommended in the Indian eyes. Barrett 2 formula is the most accurate formula for calculating IL power, followed by Hoffer-Q formula. Thank you.
Renu ma'am, your opinion for undercorrection?
Yeah.
Yeah, for less than 2 years.
So we followed the Hahn and residue.
Yeah, but I feel there is a lot of controversy. Some people say 20% is too much of undercorrection even for 2 years. Go for only 10% because in a long-term study, after 10-15 years, they are becoming a lot of cases we are getting. So that 20% formula for per se, most of the people have gone like.
So Dr. Coker published a study saying that in Indian eyes, the myopic shift is less. Like you should not undercorrect by 20% because the myopic shift is less. But in our study, which is like we did
that's what I was thinking.
It is
why
more.
so much of controversy?
So
like,
there's so much. There's so many variables involved. In the first post-operative, refraction that we do, is sometimes we get a myopic shift. So it may be the formulae that we are using, whether we are using Hoffer-Q every time or SRKT, SRK2. Dr. Coker also says that SRKT, SRK2 is the most accurate, but we didn't find. These are smaller eyes. Hoffer-Q is better. Barrett 2 now, they started using Barrett 2, that's better. So the first thing is the formula that you're using. So first post-op refraction has to be correct according to the formula that you use, even if you undercorrect by 20%. And then, at least in this, all the patients that we took, there was a significant myopic shift. And younger the child, more the myopic shift.
Yeah, so, but when we undercorrect, we have to go for the other part also. Sometimes it's difficult to treat the child for amblyopia also.
Yes.
So the second important thing is 20% undercorrection, what madam is saying, for madam's hand, it might be good. But for general people, it has now come down to 10%. Third thing is, like, it's better to keep the eye on the emmetropic side rather than a hyperopic side. Too much of hyperopia is going to lead to problem. So these are a few points which I would like to highlight, and madam, you can comment better. I think
I would say that each one of us needs to develop our own formulae. Do not follow the formulae blindly.
Yeah.
You have to keep doing, and you have to evaluate your own patients to see how it is working. So for each of us, the person doing the biometry has to be a trusted person. It has to be the same person doing it regularly. Even that, how you're measuring the exhale length, how much you're pressing, whether you're doing a non-contact contact, all these things. So it's so many variables.
So one more important point, when you are doing a biometry, same optometrist, one, and there should be two optometrists. It has to be confirmed between two optometrists.
Yes.
Second thing is, every reading repeat thrice, whether it is exhale length reading or whether it is the biometry reading, have to be repeated thrice by two optometrists, then take the conclusion. Don't go straight forward, just one reading and go ahead, then you'll find surprises and land up with problems. Thank you. Thank you, ma'am.
Thank you.